I kind of did these the order that they came in. We have some general questions, very specific ones, and I was going to try and group them together, but I thought it might be a little more interesting if we just kind of jump around a little bit to keep us awake here. So the first one was an easy one, and it was more of a reminder of me to let you guys know when you fill out the form to ask questions for this webinar, if you include your email address, because most people don't, a handful do. If I can't get to it during the webinar, I do try and answer them and reply to you by email, or I try and make a post on it on the blog. We're trying to do more video answers now. So include your email. I won't put it in, as you can tell, in these questions. I don't use anyone's name ever. I might say it's a student or someone who purchased the Blitz, but I don't use your name even if you include it, okay? So that's what this person was saying. She had a bunch of questions and she understood if I couldn't get to them all, could I email her when it was over. So yes, please do that. So in case your question doesn't get answered, I can get back to you. All right, the first question is on the integumentary surgery section about lesions. It says, in your Blitz on lesions, you mentioned each lesion gets its own code. Can we add lesions together when it's in the same bubble like repair, simple, intermediate, and complex? The answer is no, you cannot. This is a common newbie mistake of adding lesions together. You want to only add repairs together. And if you think of it this way, when we put the codes down on our claim form and we send it into the payer and they're going to translate it, if you're talking about the repairs, which are basically stitches, and you picture long lines of cuts on someone's arm and them stitching it up, it doesn't really matter if it was 3 separate cuts or one long one. It's the same amount of work. But when you're dealing with lesions, each one needs individual attention, and therefore each of them should have its own code. So I wanted to show you on the document camera, get some document camera action today. Where it is in the guidelines. Now, if you have your CPT books, it's page 62 in the professional version. So let me give this a whirl. Fingers crossed.
Yay.
Okay. You're seeing it? Yay.
Yep.
Okay, good. Let me see if I can zoom in a little bit there. Okay. And this is typically how I teach with the document camera. I'll get it up there. It's a little, shaky sometimes because it's literally a video camera on my book. But you can see my notes and how I underline and highlight, and that's pretty much what's on the recordings for our course and the review videos. So here I wanted to show you what I highlighted. It says report separately each benign lesion excised. So there's our key. It says each. And the question was about the bubble. So I'm going to flip this over here. And a lot of my technique that I teach the students is to bubble and highlight your groups of codes. So we have a 11400 bubble, and all the indented codes get bubbled in with it. Okay, and then we have the next bubble that starts with 11420 and goes all the way to the next column, 11426. Now the difference between the bubbles here for this excision of benign lesion is location. The first one is trunk, arms, or legs, and the second one is scalp, neck, hands, feet, and genitalia, and then there's a third bubble that covers all the other body areas. So if you have, let's just say, a lesion of the back, which would be the trunk, of 0.5 centimeters, you're going to report 1 unit of 11400. If you have 2 different lesions of the back that are each 0.5 centimeters, you're going to report 2 units of 11400. That's what it means by each code, or each lesion getting its own code. Okay? You don't add them together and say, oh, well, it's 1.0. I'm going to code 1 unit of 11401. That would be incorrect. Okay? So when you're dealing with excisions, each excision gets its own code, even if it's a multiple unit of the same code. Okay? And then it's the opposite for stitches or repair codes. You can add them together. So let's see if we can go back. Okay. Yay. All right. So that was that question. The next one was more of a time management question. I'm currently practicing for the CPC exam in April. I'm having a difficult time with surgery questions. How can I better prepare so that I don't feel stuck? Should I just do the ones that I know, that i.e. the quicker ones? And then another person asked a similar question. My challenges are long cases. We only have 5 hours, 40 minutes to take the exam. When the cases are very long, I realize it takes me so long to read and find an answer. So the first part about answering other questions first, certainly. Right now, it's 150 questions in 5 hours and 40 minutes. You can manage your time and answer whichever questions first you want to. It used to be you had to pass 3 individual sections, but now it's one grade for all 150 questions. So yes, absolutely, answer the questions you're more confident with first. The easy medical terminology ones, the quickie HCPCS ones, absolutely. Because the op reports are going to take you longer just for the reading alone. Now, if you've been attending these webinars, this question seems to come up every time. My main technique for the exam taking technique is to look up the answers first before you read the scenario. Very hard to do. You have to train yourself. You'll see this long thing and you want to jump right in and start reading it. Don't do that, because what's going to happen is all going to seem important to you. Then you're going to get down to the 4 possible answers. You're going to start looking them up, and then you're going to go, oh yeah, I think that was in there. Let me go back and read it. And you might even read it 3 times before you get to the answer. So forget the first time. Go right to the answers, look them up in your CPT book, and note what the differences are between the 4 codes. And you will quickly see, oh, well, these 2 are of the arm, these 2 are of the leg, or, these 2 are of this diameter, these 2 are of this, there'll be something that jumps out at you as different. This one's with anesthesia, this one isn't. This one's with contrast, this one isn't. So you'll be able to quickly throw out 2 of the 4 possible answers. And when you go and read the scenario now, you'll have in mind what you need to abstract for, what you need to pull out and do as your answer. So, so that's, yes, answer the easy questions that are easy to you first, and then second, do the looking up of the 4 answers first. Now, if you're still finding with doing that you're needing more than 5 hours and 40 minutes, what that means is you're not ready for the CPC exam. You need more practice. Okay? So it's not that the technique is broke or you're broke or anything like that. You just need more practice to get your speed up, and try and not overthink it. Okay, modifier 58 versus 76. Let's do document camera again. Now, in your CPT manuals, the professional version, the modifiers in their full form live on page 567, Appendix A. So I'm going to take you to modifier 58. Get my camera ready here. Oops. There we go. And this is staged or related procedure or service by the same physician during the post-op period. So if you've attended my modifiers webinar or you've listened to the Blitz where I cover this, a technique I use is to teach you to learn modifiers by family. So this modifier is in the global package family. So that's one clue as to when you would want to use this one. It's a global package modifier. The note that you would want to write in your margin is that the global period resets for this. So there's a CPT code or a procedure that's occurred previously, previous surgery, and now this is another CPT code that's done at another time, but it's related to the first one. You'd use modifier 58 for this one, okay? And some of the notes that I emphasized is that it's a planned or anticipated, that's what staged means, procedure. And oftentimes you'll see in CPT, like with cleft palate repair and things like that, they know in advance they are not going to be able to correct that problem in one surgery. So it'll say second stage of the procedure, okay? And that's your clue. If it's within normally 90 days of the first one or whatever the global period is, then you need to put a 58 on. Because what the payer will do, they'll say, oh, they're in a global period. They're going to bounce it back to you and say, everything's bundled in, you're in the global period. You need to put the modifier 58 on to say it's a related procedure, you know, and that's why the global resets. So that's 58, and the other modifier was 76. Unfortunately, this is on 2 different pages. I hate that. But the key here, you can see what I wrote, it's the same CPT. It's a repeat procedure, so it's the same exact CPT code, whereas staged, it's not the same, okay? And so this is a repeat procedure, same physician or other qualified healthcare professional, and let me get the rest of this code here. Same physician or other qualified healthcare professional subsequent to the original procedure or service. This circumstance may be reported by adding modifier 76 for the repeated procedure. Okay, so that's the main key. Same CPT, whereas 58 isn't. Okay. Okay, an ICD question. Sometimes the NEC rule gets confusing when coming across a code with NEC by it. Means go ahead and use that code, right? NEC and NOS sound very similar in the rule and keep thinking that they both mean the same thing. Can you give a basic, simple example? Yes. Let me get that up for my document camera. You guys should see my desk right now. I got papers flying all over the place. All right, so this... Go ahead, I'm sorry.
We can't. That's a good thing.
Oh, that you can't see it, yes. All right, so this is just from one of my introductory pages in my ICD manual. Everyone's ICD manuals are different. My publisher is the one from AMA, but it's got Carol Buck's name on it. We tend to buy the packages with her name on it. Okay, so this is what I teach my students, that NEC means not elsewhere classifiable, and it's equal to the word other in tabular, like this example here, 244.8, other specified acquired hypothyroidism. And what it's saying is that your physician has given you a qualifying term or more detail than the ICD-9 book goes into. That's why it's called not elsewhere classifiable. It doesn't fit in any of the other categories. That's why I call it the book's fault. Now, NOS means not otherwise specified, and it's the equivalent of unspecified in the tabular, like this example here, intestinal tract unspecified. Okay, this is normally what I call the doctor's fault, that there probably was more information, but we weren't given it in the documentation. So we have to use an unspecified code. That's not always the case. Now, if you have a choice between the two, other is actually better because it means you had more detailed information than the book gave you. Now, I had a page marked to show you. Hold on. All right. It's 288.0, neutropenia. Now, that's a 4th digit code, and in your book you'll have a symbol. Mine is the red stop sign saying you need a 5th digit. So, and when you look at all the 5th digit codes here, we've got 0, 1, 2, 3, 4, and 9. And that's an important point with 5th digits. They don't always, you don't have all of them in there. What you'll notice is 09 is the one that says other. That's pretty typical. The ones that end in 9 are for other. Now the unspecified one ends in 0. That's pretty typical as well, but not always. Sometimes it's 8, you know, whatever. So when you look at the choices, 1 is congenital neutropenia. 2 is cyclic neutropenia. 3 is drug-induced neutropenia. 4 is neutropenia due to infection. So 9 would be other, some other type that isn't mentioned by 1, 2, 3, or 4. Then you would classify it as other. And they give some examples here. Okay, where the unspecified means the doctor just simply wrote neutropenia. He didn't give or she didn't give any other qualifying terms. Therefore, we can't code it as any of these others. We have to code it as unspecified. Okay, so hopefully that'll help clear that up for you.